these slides to try to make up some time. There's a lot of beating heart mitral repair technologies out there for a mixture of mitral valve pathologies, both primary and secondary. This talk's going to focus very much, though, on primary mitral regurgitation due to degenerative disease. And this is basically what we do. We repair the valves. Most people repair these with Gore-Tex cords, and we tend to do some form of annuloplasty. So can we do that on a beating heart, without sort of conventional surgery? This is a device that's been around for a while. You can see here it's a slightly clunky system. It's quite bulky, and you have to put the device in and out of the ventricle every time you want to implant a cord. This is a much more elegant device, which I think you probably know has been acquired by Edwards, the Harpoon Device. I think you can probably see why it's called a Harpoon. Very interesting technology. A shaft that is a low-profile shaft, with 21-gauge needle with a pre-wound EPTFE suture. When you puncture the valve leaflet, this unravels from the shaft and ties itself in a knot, which is the anchoring mechanism. Perhaps the big advantage over a neocord is this dedicated hemostatic introducer, which allows you to put multiple cords in through a single ventricular puncture. Here is just a quick animation. I'll just show a little bit of this. A nice foot plate here, which allows you to see the device. You fire the needle, the knot is formed, and you exteriorize the suture. Here is one of the cases that we did. Pretty standard posterior leaflet prolapse. Here is the device being introduced. Oops, sorry, I think I've skipped a slide. So here we have tenting of the leaflet and firing of the device. And this was one of the patients we did. This is a very broad P2 prolapse, and these are 6 knots, Gore-Tex knots, pasting the leaflet. And you can see here the leaflet is pulled down, and you get a very nice surface of coaptation. I think this is an important slide. This is 6 months out. I think this, to my eyes, looks very different to a surgically repaired valve. I think you would struggle to say that that's not a normal-looking mitral valve. I think it's one of the exciting things about this technology. This is the early experience reported in JACC. So, but we also do annuloplasty. We do cords and annuloplasty. So can we do this in combination? Well, you can. Here you can do a band, a percutaneous band with the cardioband, or a complete ring with this Millipede device with a sort of cinching mechanism. And there's a small number of patients being done in Europe where they have concomitant cardioband implantation and MitraClip or caudal implantation. So purely catheter-based replication of what we do surgically. So what about the emergence of beating heart mitral valve repair? Is there an unmet need? There's an enormous unmet need. If you look at the amount of mitral regurgitation and the proportion of these patients who are treated. Might beating heart surgery change referral practices? We have this risk of surgical intervention. I think at this end, patients are declined or do not have surgery because the risk is too high. And at this end, patients are not referred early enough in the natural history because patients don't want to undergo conventional surgical procedures on bypass. So one end of the spectrum, here's a patient with a fairly straightforward mitral valve lesion, not a very straightforward patient to operate on. Here's the result of caudal implantation producing a pretty competent mitral valve. So what about the other end of the spectrum? We've already heard patients want minimal access, okay, but they also want to avoid bypass and ischemic arrest. If you talk to patients, they don't want to have their heart stopped. They don't want to have a pump run. So, and also cardiologists are reluctant to send patients early for surgery because of that. So a truly minimally invasive beating heart procedure, which importantly preserves all options for the patient, may facilitate referral for intervention earlier in the natural history of the disease. Do we always need an annuloplasty? Well, remember Carpontia's paper. Most of the data requiring an angioplasty were patients who had extensive posterior leaflet resections. Well, of course, if you take a whole load of tissue out of the valve, you have to put a ring in to make the annulus smaller because you would have a mismatch. So most of the data that we have about this need for annuloplasty comes from these kind of procedures. Here's a Harpoon case from our institution. I hope you can see there seems to be a change in the geometry of the mitral annulus just by implanting cords. This is very preliminary data, but you can see here in all of the 9 patients looked at, there was a significant reduction in septolateral diameter of the annulus just by implanting the cord. Do we need a heart team? Well, this is Russell Brock. So we have to remember the first procedures ever done on the mitral valve were beating heart, mitral valve repair, closed mitral valvotomy. And he set up this Peacock club. I'll skip this, but this was really the first heart team. And he wrote in relation to this club that he set up, intracardiac surgery is not for the lone worker. Teamwork is essential. Cooperation of colleagues. More and more people are drawn into the team. I think these words still hold true today. The team is essential. This is an extended mitral team that we have at the Brompton. If you're going to do these kind of procedures, though, you need an implant team. You need a dedicated interventional imager, somebody who actually intervenes with the imaging during the procedure. That person should do the pre-procedural TOE and the procedural TOE. It needs to be a dedicated person, not anybody who's just passing through the lab. You have a cord implanter, and you also need a dedicated anaesthetist. You need the heart rate controlled. You need to really have standard preload and afterload, so you're judging the length of these cords with the patient's physiology being in a normal way. Communication is essential. You have to, all of those 3 people have to be able to communicate. How do you acquire the skill set? Well, the first thing is you create a team. You need to learn the interventional language, because you are using guide-wise here a bit. Go on the Edwards TAVI training course. You'll get all of that from that. You need to become an echo expert. You can't just have somebody telling without you really interpreting the echo. Go to meetings and trainings together as a team. And you probably need to go to the cardiology meetings. And probably these commercial meetings are better than the society meetings. You need to go to the valve and particularly the imaging sessions. And then you'll start getting the skills that you need. Because all of you, I'm sure in this room, can puncture the ventricle and move the device around, but you need to get an understanding of what's going on. If you really want to go in this is Francesca Mazzano set up this program at the University of Zurich. This gives you 300 hours of dedicated training in structural interventions. It's a little bit expensive, but I'm sure if you put a few Inspirus files in, Edwards would pay for it for you. Have a look at this website. It's a very, very, very interesting concept. This is the most important slide. This is, to my mind, the future of mitral valve surgery. This is beating heart correction of posterior leaflet prolapse. I'm sorry that it's not running particularly well. So here you have your P2 prolapse. You pull the cords down, and it's gone. And you let the cords go, and it comes back. When you do that, it is incredible what you see. You see the systolic blood pressure go up about 30 millimeters of mercury. You see the filling pressures drop. Immediately you correct the valve, and it all reverts when you go back. I think one of the reasons why we see these still disappointing rates of mitral valve repair is we're trying to teach surgeons how to operate on an arrested heart and a valve that doesn't move, and they have to learn how to correct that to make it competent when the valve works. Here you don't need that. It's obvious when the valve works and when it doesn't work. So this is the conventional surgical attitude towards innovative approaches to mitral valve pathology. This is, I think, a more enlightened approach, but I would put to you that I think minimally invasive mitral surgery is not just minimal access. It will mean avoiding bypass and avoiding ischemic arrest. Thank you.